So today's lecture is entitled Healthcare Services in Rural Areas. We'll just give you a brief introduction to the CV of Dr. Saadeh, who is Assistant Professor at the Jordan University of Science and Technology. He has earned a Bachelor of Dental Surgery degree from Jordan University of Science and Technology, a Master of Science degree in Public Health from Tulane University, US, and he completed his academic studies with a PhD in Environmental Health Epidemiology from Indiana University. He has also completed the residency program in dental public health from the University of Texas Health at San Antonio. His research focuses on environmental and social disparities among communities, with special emphasis on vulnerable groups such as children, elderly, and populations with low socioeconomic status. So without further ado, let's give the floor to Dr. Rami for his lecture. Thank you.
Hello everyone, welcome back. So today we'll be talking about healthcare in rural areas, which is a very important topic, and this topic, as we have discussed yesterday, is one of the approaches that was been advised by the Global Committee to outreach and approach those who need, especially poor people and people who have low literacy and don't have insurance or access to healthcare. So basically we are introducing a very important approach that has been advised as a way to find those minorities and serve them in the right way. So, you know, the community in general need access to care. So this is one of the basic needs. If you don't get an access, even if you have insurance, even if you have money, if the access is not available, that will be a problem for you to be able to find the services and the healthcare you need. So access to care is defined as the timely use of personal health services to achieve the best possible health outcome. So the time you use is based on your the time you need it. So if you need the services right now, it should be accessible the time you need. If it's not accessible by the time you need, that means you don't have an access. So if you have it yesterday or the year before or before COVID-19, that was the access of care at that time. So it's a continuous process that you need a timely basis of access to care of the needs you have. So this is basically that has to do with your individual as a person to achieve, of course, the best possible health outcomes. Because if you are just only need basic services, this is also a limited access to care. So it might be you have access to care, but this is limited access to care because you don't achieve the best possible outcomes that you need for your health. And accessibility is actually evaluated with affordability, because if you don't have insurance, even if the community health center or primary health care center, as we mentioned yesterday, is next to your door, but you can't afford it, if you have insurance or if you don't have the money for that, that means it's not affordable for you. Proximity, this is also another problem in rural areas. This might not be a problem in Cyprus because of the almost proximate and nearby locations of different communities for their health services, and rural areas existence is not a big issue as far as I know, and you can correct me at the end of this slides. I have some questions about that. And quality of care. So as we said, if you have access to care, you can get to the health care you need, but the quality of care is limited, is not good, is poor, which is not the best possible health outcomes you need. That means the quality of care is not the one you need, and the quality of care is a limited access to good health care. So, okay, here we have some myths about rural areas. So myths is something, false beliefs that has been for a long time been transferred from a generation to another. So these are the wrong ideas that has been, for a long time been, conveyed as a image for something. So it's a myth. So the old myths, so the old ideas wrong ideas about rural health, that, you know, urban care quality is better than rural care, because if you have a big city, that means everything is big, everything is better. So this might be true in reality, that because of the cities, big cities usually have big hospitals, but the big hospitals does not mean always means good care or access to care. Imagine a big hospital that serves so many people. How many people can get an appointment, get the time to be seen by a doctor, and the time of appointment, how long or the duration will be a few minutes, 1 hour, half an hour. Even though most of these private hospitals or big hospitals will be most likely asking or looking for money for financial benefits. So how many people can afford, and what kind of insurance can cover your services if you live in an urban area? So it's not always true that big cities have a better quality of care, or you will be able to achieve the quality of care you imagine or you look for. Maybe you live in a rural communities and you still get good care. It depends on the place you live and the primary health services provided by your government and the health insurance that is available to you as a person or to the community. Another myth again, a wrong idea or poor image that has been conveyed over generations. Rural residents do not care or need local health care. And this is absolutely wrong. Thinking about rural areas, and by the way, maybe I did not define rural areas. Rural areas are those who live in the countryside, who live far from the cities, like villages, small towns, or even in the middle of nowhere. So those who does not live in the city, they live outside the city limits or outside the city boundaries. So they live in a very far areas. That means rural. So another myth, as you said, the second one is that they don't care or need local health care. And this is not true, not because they are poor or mostly low educated. They don't care. Many of them actually care, and many of them look for services. But unfortunately, they have been overlooked and completely avoided in the care that is provided, because usually the business and the economy is centered in big cities. The third myth is people in rural areas are poor and can't afford cost of care. Not all of them. Some of them are poor, but I can give you one example from my country, Jordan, that some people who live in the desert, like Bedouins who have, raise sheep and goats, actually they have a lot of money because of the hundreds of sheep and goats they have. They can only sell one goat and go to the dentist, and we see that very often. So this is how many of my friends and people, doctors and dentists, ended up opening their clinics in Bedouin areas. And Bedouin means those people who live in the desert, having camels, sheep and goats. Many of them are very rich, by the way. So it's not always the case that they cannot afford the cost of care. And actually, they look for a good quality of care. And this is a little bit new. They always ask for who's the best doctor to go to, because they have the money, they can pay, and they don't usually negotiate. Rural populations are disappearing, and this is also not true, especially with urbanization and globalization and issues related to them. I have been seeing the documentaries in many big cities, in New York, Boston, Sydney, these cities, Tokyo, that are extremely expensive. Actually, people are now leaving these big cities, and even rich people are building their houses outside the city limits. So it's not true. You might find rich people leaving the city center, and going to the countryside, or as you can define them as rural areas. So basically, if you believe in this myth, if the policymakers, if the government officer, health officer, administrator believe in any of these myths, again, primary healthcare, community healthcare in rural areas will not be supported, and will end up actually in abandoning the rural health in these areas. So we should be careful about these wrong images for rural health. Okay, there are some barriers to healthcare in rural areas. The first one is distance and transportation. I know that many people have cars in rural areas, but many don't have cars. Even if they have cars, like older people, and we will have a slide in a few minutes about that, they can't, drive their car because of the elderly and the age of the person. This person, or a woman or a man, because of the age or sight, they can't drive, or because of the disease. So even the transportation can be a problem, even if they have a car. Distance is another issue that people cannot approach healthcare because of the long distance. I still remember in some cases in the U.S., because the U.S. is a very spread out, continent or country, that in some old towns and villages, a woman who needs to deliver a baby, who's pregnant, needs to deliver a baby, might need to drive 2 to 3 hours. And even sometimes more if she's starting to have labor. So this is very critical. And many of the cases, you might have seen some of these videos, she might deliver on the way. Health insurance status, some, not all the people are not insured. Some prefer to pay, money if they have enough coverage or money to do that. But again, many have health insurance problems, and the reason for this, they don't have stable jobs. If you have a job in a company or a business or government, you usually live in the city, right? So you are covered by your company or a place of work. But if you live in a rural area, and you don't have any stable job, that means you are not insured. This is one of the main reasons. Health literacy, we will come shortly to health literacy, but literacy means the ability to know or have a knowledge about specific thing, reading and comprehending this thing. So health literacy is the ability to understand the information related to health, and there are a few slides about it. Stigma is a big issue, and I remember one of our friends, if I can spell the name right, Efthymius, I'm sorry if I spelled it wrong, actually mentioned one issue about stigmatizing adolescents, youth, and other adults for sexual and reproductive health in rural areas. And this is very important. We'll come to this in one of the slides. And again, there are many projects about that. Workforce shortages, and we mentioned this a little bit in primary healthcare yesterday, why people prefer not to work in rural areas because of the money, the distance, the privileges, the career advancement, the prestige. There are so many ideas going on in the healthcare providers, why they don't want to stay in rural areas or serve in rural areas. And we mentioned some ideas yesterday how to attract them to go to work in rural areas, if you remember them. So remember the first one, it was transportation and distance. And this is an image for older people who needed help. Imagine those old women and old man, they can barely walk. How do you imagine they can follow up with appointments and drive every week or every 2 weeks to see the doctor in the rural areas? So this is actually a problem. This slide is supposed to be on the left, fine. I don't know what happened now with the words. So I put some words to show how long distances and access to care are all related together. But things are, I don't know, the words are messed up here a little bit, maybe because of the slideshow, but it's fine. The whole idea is transportation distance is a problem, especially for elder people and people who have disabilities. So the person who is disabled, cannot move, cannot walk, cannot talk, cannot drive, how this person will be able also to go to the primary health care or the healthcare services in rural areas. So this is one of the barriers. Also, health insurance, it was the second point that we mentioned. I gave Jordan as an example. We have almost more than 2/3 of Jordanians covered, but this is honestly is not enough. We still have around 1/3 of Jordanians not covered by any kind of health insurance, so they have to pay out of the pocket. And these are usually people who are either very rich or very poor. So very rich, they have their, they have money to pay off any clinical services fees. but also very poor. So it depends which kind of people are they. Or actually we have other people who are Bedouins in refugee camps. Now in Jordan we have about 1.2 as an official estimation for Syrian refugees in Jordan, but the reality maybe we have something around 1.7 million Syrian refugees. We have about maybe 300,000 to 400,000 Palestinian refugees that has been in Jordan for many generations right now, living in Palestinian refugee camps. And I work in one of these camps. The situation is not very good. And some Bedouins who are poor. So not all Bedouins are rich, some Bedouins are poor. So these are really rural, distant people who are really resided and existed. But for the Syrian refugees, we have the UNHCR who are supporting them, and for the Palestinian refugees, we have the UNESCO supporting them. Of course, the benefits are not great. There are long lines and long waiting lists, so they prefer even anybody who has money from Syrians or Palestinians to go up and to any private clinic and pay the money and just not just to stay on the line. Bedouins are the same. And I saw some Bedouins and people who live in very rural areas. Their teeth are broken. They might have a poor sight. They might have some other diseases like diabetes, and they are not aware of any of that. They never actually cared or even knew that they should be seen by anybody. So here are some questions that are related to the information that we mentioned. Can people in rural areas afford a good health insurance? I think we mentioned this, but basically it depends on the person. Can citizens of rural areas afford the prices of high quality care? And this is also related. So some people say that, and I put these questions because maybe at the beginning you would say no. But after I mentioned several examples, it might be yes, and it might be no. Does a healthcare provider charge lower than their counterparts? What do you think? If you can give me some answers. So if you work in rural areas, do you think you will charge less or no? What do you think? Any answers by messages, or if you like just to go ahead and say it. Any ideas? So, for example, I worked in Palestinian refugee camps in Jordan. Like that was 17 years ago, and we used to charge less. But some other dentists, actually, I was working there as a dentist. Okay, my friend also, there should be lower cost for removal. Yeah, in general, lower, because you take the average estimation of expenditure and the GDP for people who live in rural areas. So it's based on these statistical estimations for the average salary, average income, not salary, because most people are unemployed, they have self-employment, and based on that rate, you decide. Some countries actually they can provide you with estimation for how much you should charge in rural areas, and some countries are not. So it's all based on your judgment. But I would say in general, yes. But you would be surprised that some people don't care income. But most of the countries, they usually charge less, because this is the average rate in general is basically lower. And again, if you charge the same price of people in the city, people in rural areas will prefer to go and drive to the city to be seen by a doctor and pay the same amount they pay you in the rural areas. The only way they can encourage them to see you is the distance of the travel distance and the price. So we have another web people as okay. Let me see the message. Yeah. Whether people in rural areas afford the good health insurance depends on how we decentralize in the national public health system. And this is completely correct. The decentralization of healthcare and the national coverage of healthcare is important, and we will discuss that more in details tomorrow. But this is important, as our friend Loveness said. So yeah, it depends. It depends. But again, you should be a little bit competitive and attractive to people who come in rural areas. So one of the things to attract them is to have a little bit lower prices. So health literacy, we mentioned the third problem is health literacy. And health literacy is the ability of patients to understand the health information or any information related to the health. And even instructions when you instruct them. So they may have general ideas or information about health, but when you give them specific instructions, do they have the ability to comprehend and understand them? This is very important. And there is a wide variety in the ability to understand and comprehend the health information. But honestly, in general, people who live in rural areas usually have low level of education because they grew up as farmers or grow up, taking care of shepherds, like taking care of sheep and cows and things like that, or have a small business here and there. Usually, if they have very good education, like higher than bachelor's degree, they go in the cities and start looking for a job or travel or complete their education. So it is really a very correlated relationship. It's not a direct relationship or association. It might be an association, but also it might be a correlation, just things that go together. But it might be true that people in rural areas have a poor health literacy. They tend not to understand the instructions given by the healthcare provider. So you have to be careful how you communicate with them. And a very nice note to mention here, there are actually health communication skills that you have to gain before you go and work in rural areas. Because it's not only the level of understanding and comprehension, but also the culture there. Sometimes the dialect and language and the traditions. So you might go in a tribal area or area that are very conservative, and you have to respect them and be careful of what you say. It might cause problems too. There are examples of that. Okay, health literacy. The main factor causing poor health literacy is low socioeconomic status. And low socioeconomic status includes the financial situation, the educational level, the social level, the also behavioral issues also related to socioeconomic status. So socioeconomic status is a very wide definition, but many of the people who have poor health literacy have a poor socioeconomic status. Anyway, the low health literacy would cause the following: low communication, and this is important. You have to be the one as a healthcare provider. If you are a nurse, a doctor, a dentist, a physical therapist, occupational therapist, physical assistant, whatever the physician assistant, whatever the job title you have to be the one who initiate the talk and be able to break the barriers of those people who have poor health literacy, because those people tend not to talk much, are afraid of saying something wrong, are a little bit shy that they don't understand what you say, and they don't actually admit or commit saying that we don't understand what you say. So you have to be careful, and you have to be the one who has the skills to bring up the information, find a way to convince this person, tell the instructions you have in a nice way, and make sure that this person understands you. This person who have poor health literacy, like an uneducated old man living in a rural areas who's a farmer, this person will never ever tell you that I don't understand what you say. So you should be very keen and smart and know how to communicate with this person. Fear of misunderstanding. So they always have this image that they will not be understood. So this is actually another reason they don't talk much. They don't ask questions. And even I tried even myself when I ask them, do you understand? They shake their hand, shake their head like, okay, yeah. But if you ask them my questions, any question, you will find that they don't understand. So fear of misunderstanding or being misunderstood. Feeling of inferiority. So, people who live in rural areas, and some doctor come from a city who speaks up-level language, and have a lab coat, and you have a degree and have a title on the office, doctor, blah blah, they feel they are lower than this person, so they feel a kind of should be a little bit afraid and ashamed and inferior to themselves. So we should actually make them gain trust, feel proud, talk with confidence. This is very important. And actually, to be honest, all this needs time. You have to build trust with the people, with the community. They should like you, and then after that, all this can be broken and improved. And this also has been proven by trials and by observation. There are stories of that. Okay, there is a question. It can be an advantage if the community has no other choice. So if the community has no other choice but you, they don't have so many choices, they don't have so many doctors, they only have this one person or little, or few types of services that are available. What do you think? How these few available services or few people who are available to serve them could be a way of something that is good and advantage to the community? I answered one question was appreciation. If you only have like 2 or 3 doctors serving the whole area in rural areas, or one doctor even, and one health community center in your area, you will be appreciable to this place that exists, right? What other advantages do you think if you live in rural areas and you don't have many services, you only have one type or one center serving you? What do you think the advantages are other than appreciation? Any ideas? What do you think about frequency of going to the same place? So I will give an example. If you have 3 community centers in your area, this is one example, and the other example, you have one community center in the second case. So in which case you will go more frequent to the same center, in the first one or the second case? It would be in the second case because you only have one, and whenever you need, you used to go to the same place, right? So over time, you will build trust and a good relationship and a reputation with this place, right? Because you keep going. And it will build a good relationship with the team leaders and healthcare providers. They will build a good relationship with the community, and they will know community one by one. And this might actually transfer into personal and social relationship, not only clinical and medical relationship. So the relationship will be even stronger than having different centers and different people. People will be able to go frequently, be known very well, develop trust, and make a strong relationship. And this will make it easy for them to make changes. So imagine one community, one healthcare center, the relationship will be very strong, build the trust quickly, will be greatly appreciated, and change can be easy. But if you have many healthcare providers like private sector, government, community center, and non-for-profit organization, people will be distributed and change from here to there, and no strong and continuous relationship will be built. I hope you get the point of what I said. Okay. The first point was about stigmatism or social stigma and privacy issues. As we mentioned, there are some traditions and beliefs in every community, and there are so many examples. Like in my country, in Jordan, there are certain beliefs and traditions. If you go like to Bedouins and you say something wrong or do something they don't like, you might be in a problem. If you go in a village, it might be different. If you go in a city, maybe there are no cultural issues. Same in Cyprus. It depends on the area you go, in the north, south, village, town, city. Also, conservative community, open community with religious or traditional beliefs, it plays a role. I want to mention something here new in Cyprus that I noticed. You start to have so many refugees maybe in the last 10 years, maybe, or 10 or less. 4 or 5 years. So less than 10 years, the person. So 5 years. Imagine the cultural structure of the capitals of this, what you call it, Cyprus society. Yeah, is changing, and the ideas about the behavior of other communities will change over time, and actually this will develop a new theme of services that can be able to approach those refugees, and I'm sure the refugee community is even growing. And I also noticed it's not only one type of refugees coming from one place, different kind of refugees coming from different backgrounds and different countries. So it looks like Cyprus will have a mixture of cultures and the beliefs, cultural beliefs, traditions, and different communities. That will be, you know, you cannot go out to somebody, I will not say mention a word, but somebody who is very conservative from X country, and for example, tell them that you know, we should do a pap smear or do HIV test for them. They would think this is, you know, big, you know, sin, and you know, you cannot even ask about it, you know, or ask a lady who's 17, 18 years old, do you have a boyfriend? In some cultures, this is not even accepted to be asked. In other cultures, it is fine. So we have to be aware of this. And we mentioned sexual health yesterday, and how adolescents and youth in many countries, in my country is one example, maybe here in some areas as well, is an abandoned talk and some sort of taboo that you cannot talk about. But actually, we have seen many issues with reproductive and sexual health for adolescents and youth before and even after the age of marriage. That should be addressed, and without addressing that in the healthcare system, by making services available to them and policies that protect them, it will be a growing hidden issue. So we don't want actually this issue to be hidden among adolescents, the sexual and reproductive health. We want that to be something normal, that within the boundaries of culture to be respected, but should be something that is available to all, discussed clearly and surely, and not to be hidden and you know, avoided, because it will cause even bigger issues. And you might actually know what I mean. Also, mental health. So imagine that you go in a rural areas, in example, my country, in a village, or you know, and still somebody, you have, you know, some mental problems, you should see a mental health clinic. You know, in my country, you would say, what do you mean? Am I a crazy person? Do you say that I'm, you know, stupid, have lower mental abilities than you? And this, you might, you know, end up fighting with this person. If a healthcare provider even tell a woman in front of her husband you have some mental issues, the husband will come and maybe fight with you, because they think you are actually accusing them and blame, you know, calling them bad names by telling them they have some mental issues. So this might be more accepted in a highly educated area, with you talk in a private talk with somebody who's very well mindset, have a very good mindset, and tell them, you know, you might have some you know, mental issues that should be addressed with a mental health care provider. This person might be understand it. And actually, if I give you an example in Jordan for mental health issues, and maybe 15 years ago, nobody would accept to be seen by a psychiatrist or a psychologist, you know, thinking that this is social stigmatism and not accepted by the population. However, if you if now you go to my country, to Jordan, people would accept it. Not everyone, but many people would be accepting that, you know, in an open mindset, and we didn't have a problem. If you look at the second question, also imagine that you have ladies in rural areas, another lady in an urban area. Which one do you think will be accepting a pap smear? And a pap smear is something that is usually taken for ladies to examine if they have the HPV virus and make sure they don't develop carcinoma. Even this is something very protective for ladies. Unfortunately, many people in rural areas will not be accepting this. I mean, they would say, how can a healthcare provider, even a nurse, close my wife and see her private areas and take a pap smear? Something that's, for them, is something big and shameful. They wouldn't accept this. So this is part of the cultural belief, traditions that you might actually be coming, in your practice. And actually, these needs to be addressed. I would say something very important: substance abuse and mental health issues are growing everywhere. Are growing in rural areas, are growing in urban areas, are growing globally. So these actual issues should be addressed no matter what, and the government should make serious efforts to address, even if there are some cultural barriers, to address these issues in rural areas no matter what, because mental health issues will guide or will lead to very dangerous health behaviors that might end up in crimes, which is the same for substance abuse. So these are serious issues that should be addressed. Of course, sexual health, as well as I mentioned previously. So there are other risk factors. So what we mentioned is barriers. So access to care by transportation, stigma, healthcare coverage are actually barriers. But there are risk factors that would make people at a higher risk in rural areas than in urban areas. And these are, I mentioned, of course, not all of them, but these are one of the main ones. Aging, the rural population is aging, and age has by itself a lot of risk factors who are developing many diseases, chronic diseases. So aging is not a problem by itself, but because many older people live in rural areas, so they tend to develop many, if not many, some chronic diseases that really need a lot of care and good quality care in rural communities. Substance abuse also is a risk factor because usually you tend to have less restrictions and regulations in rural areas. Therefore, it will be an easy getaway for people in rural areas, even dealers, drug dealers, who sell and trade with drugs and substances, illegal substances, tend to use the rural community for manufacturing, transferring, storing the drugs and illegal substances. So they try to use them. So rural communities might not be themselves the one using the substance. They are actually, many of them, using it, but that may be abused and used by the traders and dealers, drug dealers, for their sake. Agriculture, of course, agriculture almost always occur in rural areas and villages and towns and farms, not in urban areas. So imagine all the risk factors that come with agriculture: pesticides and toxicity, injuries from machines, big trucks and devices, and tools that used for farming, heat shock because you stay there for too long, other kinds of things that you might get a bite by a snake or etc. So anything that's related to the land, farm, and agriculture has a lot of risk factors. Safety concerns because of the road accidents, people don't drive safely. There are a lot of crimes that happens in the rural areas because of the less monitoring by the police and other things. Domestic violence, this is a very important issue that has been addressed in so many reports by the WHO and other organizations. And I know that this is for a fact in the US and in Jordan and many other countries, there is a higher domestic violence in rural areas. And if you don't know what domestic violence is the social violence that happens inside the family, usually practiced by the male over the female, and a male might be a brother, a father, or a husband. Mostly, overall, I think maybe 70 in some cases to 80%, it would be by the husband practicing violence, insult and harm to the woman. Then it comes the brother, then the father. I think this is the sequence. So domestic violence is the, and sometimes it's funny that a little percentage of domestic violence happens from the female to the male. Of course, it's rare, but most likely the man would abuse the woman, and happens more frequently in rural areas than in urban areas. Annie, I would love really to hear what you know about domestic violence in Cyprus, if you have any information. Anybody knows any information about domestic? I know Cyprus people are very nice, but violence might still exist. So Annie?
We can fight bullying, but it's domestic violence is not bullying.
Bullying. Yeah, violence is insult, and they have a definition for a physical, verbal, sexual insult and harm that is caused by usually a man over a woman. So any statistics or information about violence? Anybody who would like to share anything? Nothing. Maybe you will remember something. Hopefully, at the end you will tell me. I would love to hear this. So I have a question at the end. What kind of expertise and quality of care do these factors need? So we mentioned really serious risk factors that need to be well addressed and needs efforts. And so we mentioned aging and the chronic diseases related with aging, substance abuse, agriculture that needs a lot of precautions, safety concerns. So do you think these risk factors need simple quality of care and simple health services, or they need really good quality and advanced healthcare service? Because you need behavioral health, you need psychology, you need emergency services, you need a toxicologist like in pesticide toxicity, you need people working with children, people working with adults, you need consultants, you need people who family doctors know about chronic disease. You need a big, really large set of healthcare providers that have wide different specializations and good quality of care to take care of these risk factors. So I mentioned this question just to tell you that there are risk factors specifically related to rural communities that are actually need a big and huge and advanced quality of care. So if we think that rural communities really need something simple, we are wrong. And the reason is because they are associated or encountering huge risk factors that should be well taken care of. And these risk factors really need good and wide variety of healthcare services to provide to them, to cover them, willingly and crucially. So this is the determinants of health in rural areas. This is actually in the US, and it's one of the examples I just found an overall estimation of different determinants of health. And determinants of health, as we mentioned yesterday, are these main factors that determine the health outcome in the community. And as I mentioned previously, the biggest and the main one is the socioeconomic factor. Socioeconomic factor is the main one to determine the health, the main one to determine the health literacy level, the main one to determine the access to care. So socioeconomic, almost, it's not 50%, but 40%. The healthy behaviors, and I mentioned there are so many healthy behaviors and problems in rural areas like substance abuse, mental health issues, safety issues. These are all related to health behaviors, and this make a 30%. So socio-economic factors and health behaviors make 70%. Clinical care, because we said 20%, so 1/5 of the determinants of health outcomes are related to clinical care, and this is because we have a shortage in workforce and we have also insufficiency in specialization. a medical specialization in rural areas. The physical environment we mentioned, like agriculture and the structure of the environment, the roads, things like that, only 10%. But if you think about where you should start, I would start in socioeconomic factors. I would improve the level of education, the jobs, and the social life of people living in rural areas. If I can improve that to 70, 60, 70%, I would easily save 30%, which is 1/3 of problems and poor health outcomes in rural communities. If I improve only one half of health problems like substance abuse by half, mental health issues, safety issues, I would save 15%, because one half of 30% is 15% of poor health outcomes, and improve the determinants of health in rural areas. So if we think any of these we could target in rural areas, you could basically improve the determinants of health significantly. Okay, and there are some other considerations. So as we mentioned, there are differences between countries, and we already mentioned this. But I would give an example, and I was happy to give the example previously about racial and cultural differences that happened in Cyprus in the last 5 years because of the migrants and refugees. But if I take one example, a big country that has been taking refugees, immigrants, and been widely mixed, which is the U.S., there are so many factors that I really lived and seen and noticed in the U.S. that would really characterize the rural health and rural communities. So it really differs. For example, the ethnic backgrounds. It really differs if you go to a Hispanic. Hispanic means it's not only Mexican in the U.S., but anybody who's Latino, they call it Latino. So basically from Latin America and South America, they call it Latino. So this is a basic an ethnic background. Could be a racial background, little, but there's some difference between ethnicity and race. So ethnic background, which is really different than, for example, Indian American, the original Americans who lived in America hundreds of years ago. They have different cultures. They have different understanding of health. They have certain beliefs. Some of them are more protected than others. The population numbers are different. The problems are different. Their expectations are different. The style life is different. So if you go to a rural community, again, as I said, was Hispanic, every kind of healthcare service that you provide and expectations, goals, the settings should be different than if you go to American Indians, who are the original Americans of the land. There are also cultural, religious issues. So if you go to a certain religion, you should be also considerate when you talk to them or give them advices than other cultures. Also, geographic distances depends on if you go to Alaska, for example, because I have a colleague who was working in Alaska, which is distant rural state. The whole type of services and the approach used there is completely different, and because of the distance and sometimes of the heavy snow during winter, they use a lot of telecommunication and telehealth. And there is a whole lecture about and this is completely different than areas where they don't have any technological settings, and you should actually physically approach them. So there are so many factors that characterize the community that rural community that trying to serve, and you have to be considerate for this. And this is actually starting to happen here in Cyprus. So you have refugee communities that should be addressed differently than locals here in Cyprus, Cypriots. So there is actually another participation by, I'm sorry if I pronounced that wrong, Louise, saying yes, is a good example of multi-ethnicity, but a pattern as far as healthcare provision, of course. And actually, we will mention this tomorrow about different healthcare systems, and we will mention how the US is far away from many It's not only rural areas actually, so our friend here said US is a good example, multi-ethnicity, but a bad one as far as healthcare provision in rural health areas concerned, given the absence of national healthcare system. This is completely true. We'll see that tomorrow. So care provision is more important than the diversity committee, of course. But when you provide healthcare services to any community, if you have and actually this is very important to mention, although the US do not have a national health system, they still serve your community, and I visited them. I visited people, migrants, I visited people in African Americans, so many of them. There are so many community centers supported by stakeholders and supported by charity organizations who support these places, and sometimes they get funds by applying to grants from the government. So they have different resources, although they don't have insurance, but they have funding and charity and other support from different resources. So they open the community center, and I visited some of these places and saw people, even if they don't have any documents and they are completely illegal in the country. So in the US, it's really it's a different situation. So you will be surprised that in every community who do not have any kind of health insurance, they still have a community health center because of the efforts been driven by people who would like to do good for the community. And there are so many examples I have in mind. Maybe you can discuss some of them in other places. So what I want to say is something good to think about, that here in Cyprus in the next few years, you will start to see these actually differences, the cultural, religious, social, ethnic differences, that you would actually be changing the way you talk or you approach your patients and the way you serve them. And you might not notice this now because many of the refugees live in cities here in Cyprus, but in the next few years, cities will be full of them, and this will start to move to work maybe in farming and other things in rural areas. Okay, we need all these kind of services in rural areas, and these are actually basic healthcare services that should be provided. Yesterday, the whole topic was about primary care and the importance of primary care in general, not only in rural areas, but other things are important. Why I mentioned dental care? Dental care is poorly served in rural areas, so these are actually urgently needed in rural areas. Behavioral health, because of the health issues, mental health issues, safety considerations that we have, that actually forming about 30% of problems. That was an example in the US, but I'm sure in other places are forming a good percentage of problems that they have. And actually, because of all the time, the focus is to build a community center that's full of essential healthcare services, which is basically primary care. We only think about immunization, child health, taking care of elderly, and we forget about the rest of them. Also, emergency care. Emergency care is not well taken care of, and many of the severe emergency cases, the patient end up traveling 1 or 2 hours to find a good hospital in an urbanized area or in a big city. Also, public health services in general should be improved in rural areas as well. Primary care, we mentioned this yesterday, but the thing that I really did not, we focused on one side, but there are other side. If you think about health promotion, which is very important in primary health care in rural areas, it's important in even urbanized areas, and we mentioned part of that yesterday, but it's very important in rural areas because it will be the same in the future, that rural areas will always receive the minimum amount of funding, a minimum amount of care, a minimum amount of consideration. So we need something that is permanent. We need to change the population. We need to change the behavior of the population. We need to promote it in the population. So this is why health promotion is important in rural areas, because we know it's a preventive a preventive approach that could improve the lifestyle and the structure and the community without paying a lot of money, because we will never ever receive the care and will of policymakers regarding rural areas. So that should be well understood, that health promotion is a very good way in preventing disease in rural areas. There are other things like counseling and education, but again, health promotion might be something that's very important. So health promotion is a way to make people more aware of themselves and make them more enabling, make them proactive. Proactivity means they are willing to do something before they are asked to. They don't have to be forced to ask about their health and be considerate for their health. They can improve their health by themselves. So health promotion is basically to improve the willing of the people to enhance their health and be able to control over their health determinants, and thus be able to improve the outcomes of communicable and non-communicable diseases. This is the WHO definition of health promotion. Again, as I said, because we have limited resources in rural areas, education is the main thing. Education is cheap. It's not if you go to the university and pay for money for your master's and doctorate. I mean by education is to convey the information and increase the awareness among the rural communities and the residents. So education here is not to get a degree. Education is just to teach people about healthy lifestyle and be able to tell them right from wrong and be able to increase the level of awareness. So you might just basically tell them that smoking is bad, smoking is expensive, smoking will destroy you, and show them some pictures about people who smoke who died early and will not be able to take care of and raise their children. You should use some emotions. This is great education. You don't have to give lectures and PowerPoint, and just simple talk with people. I really liked some clinics who made health promotion through education as part of the service. So I remember one lady who's been, for years doing health education and promotion in rural areas in one of these states in the US. She had a nurse who was hired as a health educator and has a small office inside her clinic, and she has everything she needed, as computers and screens. And she would teach every patient who come and their kids about healthy lifestyles, health problems, health issues, things they should avoid, answer their questions. So it's part of the service, and I really like this. We have some here notes. Our friend Euphemius, I'm sorry if I sometimes say it, and medicines adherence as part of the counseling is necessary always. Of course, I mean, this is actually one point that is very important, that people you tend not to commit that and adhere to the medications and the instructions of using the medication the right way. So this is part of the education. So education could be simple, just tackle down these issues that are common in rural areas and be able to address them. And Dr. Nicholas said my cardiologist is a heavy smoker, and Leonie said practice what you preach principally should apply. Yes. So sometimes it's easy to preach, but it's difficult to apply. Sometimes we say things that we don't translate into practice. It's easy to say, not easy to do. It's also a problem with us as well as healthcare providers. So anyway, education is the key. Education is important in every place, but I noticed in my little, simple experience, when you go to rural areas and talk to people who are simple and notice they trust you, you should use this trust to start educating them. I mean, trust is very important. Honestly, educated people who have high degrees, business people, when they come to your clinic, they don't really trust you quickly and easily. And usually they listen from 100 resources, and sometimes they just say, do your job and we'll pay you money. They think in a business way. But when you go to a rural communities, poor communities, and you feel they trust
they start to trust you and appreciate your work and service and like you, you should use this actually. You should use the trust to provide the knowledge they need and increase their awareness. And believe me, in a very short way, you will be loved. You will be loved, and you could be by yourself. You could change this community. Another note: the principal paradigm is a type of education for other general awareness. This, which is a model, if I understand everything is right. So you should be a role model by yourself. You know, if you are a doctor smoking, making bad jokes, and eating unhealthy food, don't do any physical exercise, other thing, it would be a problem. You should be a good model for your patients. I would go very quick because we mentioned this yesterday very quickly, how primary health care can be approached. It's the same actually approach that you could through primary health care, health promotion, it's all the same. You basically provide all these essential basic services for your community. But each time we focus something. Yesterday we were focusing on the primary healthcare services, and that was the main approach to fight COVID-19. Now we are talking about rural health and basic rural health needs. All the basic needs and primary healthcare needs need health education, health promotion. So again, these are the strategies: advocacy, investment. And it can be used in a way that would, as a strategy to promote health and serve the rural communities. And health promotion is affected by whatever affects the health. So anything you give the community or you provide is basically the outcome. So if you if you have good investment in health promotion, it will be good investment in health outcome. If you have bad or poor investment in poor health promotion, you will have a poor outcome as well. So, the strategies are all important, and as much as you put in and use these strategies, as much as of a good outcome you get. Okay, so these are strategies. There are strategies in general to promote health, but now we have strategies to improve access to care in rural communities. So we have to expand the roles of healthcare professionals. If you remember that we have these risk factors, we have emergency problems, we have safety problems, we have some agricultural or things related to jobs or careers in rural areas like agriculture that have several risk factors. So we mentioned that we have so many specialties needed in rural health. So this is why we should expand the variety of healthcare providers we need. We need all kinds of health providers. We always think that rural areas only need maybe one dentist, one nurse, and general practitioner. This is not true. This is not true. They are community. They have all kinds of needs. In addition, they have some risk factors that should be considered. Of course, we don't need 100 neurosurgeons, but we need at least maybe one surgeon, It depends on the population, but you need all kinds of services. So we could actually, what we can do, and there are some good efforts in some countries. Before I came to do this presentation, I was reading about success stories of some countries who were able to serve rural areas. There were some countries from Africa, from Asia, like Ethiopia, Uganda. And they did some nice things to serve the rural areas. So there are some examples if you support them with technology and you connect them with larger systems. So, for example, I noticed some big hospitals who are institutional hospitals. Actually, they took over some small clinics in rural areas and they connected them to the system. It's a way to make money because they get funding by doing this, and they get tax layout. They get some tax, giveaway. So it's a way to support themselves in a way, but the same way they improve the system. When a big institution take over a small village community health centers, they in general improve it. They get benefits of doing this, but they also improve it in a way. So it's good to have these networks for rural areas. And there's there are a lot of things, but we will touch based on that on health technology or technology, telecommunication and telemedicine in the next few days. Workforce development, we mentioned this, and we mentioned how we could actually attract them. So incentives, waivers, things like that. Telehealth, we will talk about that in 2 days. Building bridges with local communities. And actually, this is very important, and we mentioned this recently in the primary health care, how you can make the community the decision making or makers for themselves through community leaders, community groups, community development, and community healthcare centers who can promote health, educate them, make workshops, make leadership, who can talk and be a connection between the government and healthcare providers and the community themselves. So we should actually always think how to approach the community in a nice way. Mobile clinic or mobile clinics are another way to serve in rural areas. And this is very common in many places that they don't have a technology system. The workforce there is weak. A mobile clinic was one of the first and the quickest way to approach them. So maybe building a system or a larger network, it takes time, or maybe there's a system, or we don't find a good affiliation with some big institution that would affiliate or oversee certain rural communities. But building a connection with the local community might take time. One of the quickest way to approach the population and serve the rural communities is through this mobile clinic. Mobile clinics are basically mobile. They transfer in a big truck from one point to another. This way they can serve the people quickly, know the people, introduce the service, and they collect data and know the health issues. So just imagine there is a rural area that has never been served. The quick way to just collect data and know their issues and be able to approach them and serve them quickly and know their health needs is through mobile clinic. Because mobile clinic, sometimes they already just drive there and people will stop and start having the service. Okay, telemedicine, we will have something specific, a lecture specific on telemedicine. But the WHO actually suggested this in many reports, and even more recently they suggested telemedicine, because if you think about it, 20 years ago, actually I was surprised to know that telemedicine started in the 80s. I think the first reported case to use telemedicine was in 1986. I'm surprised because there was no internet, nothing. So maybe this was through a telephone call and some video recording, maybe. But anyway, through the last 10, 15 years, the internet actually helped a lot with connections, and even you can now have a complete video live service for free over the internet. And actually, even some additions we will see that even can add more nice items to this. Not only you can talk and see the patient, but other things as well. So it was suggested by the WHO to be used and served in rural areas, telemedicine and telehealth. So there was some applications in this, and we will see that. And distant areas took the benefit and found it useful. And actually, during COVID-19, many healthcare providers and many healthcare institutions have completely transferred their services to be from distance, through telecommunication and telemedicine. It was not only rural areas, but because even private, governmental, many services has completely been transferred. And honestly, I'm not biased toward any other country, but from my readings, and the US was one of the countries, maybe top countries, that profoundly used telemedicine during COVID-19. I'm not sure. I would love to hear if you have anything to share about the case here in Cyprus. How much have you used telemedicine during COVID-19? We can share this now or later on during the telemedicine lecture later on. There is a nice video I found that talked about telemedicine on YouTube and telehealth during COVID-19. It's a 5 minutes video. You can, see it by yourself if you'd like to. Okay, some fast, quick activity. So you can answer me yes or no. Bigger is better. Urban healthcare quality is better. What do you think? Yes or no? Correct or not correct? you can just send me a message, yes or no. So bigger is better. That means if you have something big like this city, means better things always. We mentioned this earlier. What do you think? This is an exam. I will grade you and give you a grade at the end. A grade, a mark. So you better, not fail the test. Okay. If Demas said not always, maybe no. Yes, the answer is not always correct. So rural residents do not care, need local health. Is it true? Okay, not no. Okay, not really. Okay.
Because they can transfer people to
the and they have money, they care, right? Yeah. So we are changing our ideas. If we were one of the ones who were believed in myths at the beginning, now hopefully we change. People in rural areas are poor and can't afford cost of care. Is that correct? Also no. Rural populations are disappearing. Also not exactly. The population will grow in a very dramatic and significant way, and it's believed, I think, by 2050 it will be over 11 or 12 billion people on Earth. So you'll find people everywhere. You'll find people in rural areas, cities, and under the bridge, and beside your house. We will have too many people, So I don't know what will happen on the earth, but rural areas are growing; they're not disappearing, and urban populations are growing as well. I'm not sure I found this. That this is thank you. Is that correct? Yeah. Okay. Good. So this is thank you. I don't know how to pronounce this. This is difficult for me, but I'm happy. Actually, this is a maybe easier lecture than yesterday. It was a little bit maybe more lenient. I'm willing to hear any comments or questions if you'd like to. Yeah, thank you. Anything, please? One question, one comment. Any Dr. Nicholas, maybe you would like to share something with us.
Do you teach that material to students?
Rural areas, then maybe one time. Yeah, that's all. I would love, because rural areas is very important.
But you teach other things?
Yeah, we teach community health, we teach biostatistics, we teach epidemiology, we teach and health administration. Yeah. Yeah, thank you.
But how did you come to go to the rural areas in the West?
Yeah, I worked actually. We went some.
People were in university at the same time.
I went to rural areas in Saudi Arabia, in Jordan, and many places, even in the US. So I was exposed to this.
That was a project of your university?
So my university was doing residency in dental public health. It was part of the residency program, training program, to go to rural areas and see them and talk to them and see different rural areas. In Jordan, I worked in Palestinian refugee camps. I visited Syrian. I did project with some Palestinian refugees, 2 projects. So different occasions. Yeah. Yes. Our friend. Okay. I have some questions. So Dr. Nuka said, what is the population density in Jordan? We 10.5 now. 10.5 million, of course. So this is 10 times more than Cyprus, because I know you are 1 million, right? So
yes,
almost.
At least 10 million are mostly on the towns.
In Jordan? Yeah. Most people actually in towns in Jordan, but we have many people living in actually many. I should check this. I cannot give you an exact answer now. I should check how many people in rural areas, because many people in Jordan live in rural areas. Many. But villages in Jordan are not very rural. They are okay. Primary healthcare system in Jordan is not bad. It's good. So the shortage of workforce needs more attention and more motives for health professionals. Yes. So Dr. Nicholas said IMHO rule is not that rule in Cyprus. So what is IMHO? Important information.
Sometimes it's better to just speak than write. In my humble opinion, it's IMHO.
What's that?
My humble opinion. So in Cyprus,
is what, Doctor, again, I did not hear you. The sound is now today.
Rural is not that rural in Cyprus.
Rural is not that rural in Cyprus. Okay.
Yeah, because of the show.
Yeah.
Or distance.
The distance and the size of the country. Okay. Okay. Yeah. Yeah, and this is very interesting because in every country I visit, rural is really different. Rural definition. In some areas is really very rural. In some areas is not as rural.
Probably depends in the type of communication between the rural areas and
right. Cities. Like I can give also, I'd like to travel. So in Egypt, I found that people in Delta area who work as farmers, Egyptians, this is rural, even maybe it might be 1 or 2 train stops to be the closest town or city. And the reason is these farmers in Egypt are very poor.
Standard of living
is very low, and they work very early in the morning and stay at night. They go tired, they just eat something, and so they don't have the money or even the way to seek the healthcare. So I have examples in many countries, like in Saudi, for example, in Jordan, in the US, of course, I visited many rural areas. So it really depends on the place. Okay. If, no other...
I don't know if you can hear me.
Somebody is saying something. Dr. Nicholas?
Maybe we can somehow define rural as an area where we start to experience lack of services, or we start to have difficulties of providing services, even within big cities. I don't think rural can be defined in space, let's say.
The problem today, the speakers are different than yesterday, so you can't really hear that. Today the speakers are different from myself. This is the maximum.
Okay. Can you please repeat the question? We got it almost, but it's just that the definition of a rural area is different
from one country to another,
between different places.
Yeah, what I know is the WHO has a definition for this, but of course this might really vary a lot between one place to another place. So this is true, if that was the question. We'll check this tomorrow. Okay. Okay, everybody. The sound is too. Yeah, the sound is unfortunately because I'm using the desktop today, not the laptop. Maybe I'll use the laptop tomorrow.
Okay. Any more questions, please?
Okay, everyone. There's an echo on the room. Okay.
So we'll try to hopefully solve this problem. Okay. Thank you. Thank you very much, everybody. Thank you. Okay, I'll see you tomorrow then, and have a good night. Okay. Bye.